Good morning. Today I'll talk about frozen shoulder, or known as adhesive capsulitis. So, frozen shoulder is a condition that it's a painful shoulder condition characterized by functional loss of active and passive range of motion of the shoulder. So, it involves the capsular ligamentous structure of the shoulder, and for epidemiology, usually it affects patients 40 to 60 years old and most commonly in women than men. So the pathophysiology is not really known, but it has two postulated pathophysiology. One is for inflammation, where inflammation causes fibrosis and adhesion over the capsular structure that causes reduce in joint space and subsequently progress to frozen shoulder. And then second one is due to prolonged immobilization. For example, in those traumatic patient, traumatic injury to the shoulder, or stroke patient that subsequently will progress to frozen shoulder as well. And then for etiology, the first one is idiopathic, or the primary cause, where the cause is not known. And then secondly, it can be due to post-surgical complication of post-surgery. For example, any axillary excision in malignancy patient, or post-traumatic patient like head of humerus fracture, or any shoulder fracture that due to prolonged immobilization that progress to frozen shoulder. And then the third one is when patient increased risk, this is an associated condition where patient have diabetes, either type 1 or type 2, or thyroid problem with immunological origin, then patient will have higher risk of getting frozen shoulder. So for the clinical stages, it is divided into 3. So the first one is a freezing stage, where it will last around 2 to 9 months. So freezing stage is usually patient complain of diffuse severe pain and progressively loss of range of motion. And then the pain usually worsen at night. And then second stage will be frozen. So frozen stage will be starting from 4 months and last up to 1 year. Frozen stage is where the pain, improvement in pain, but there is worsening in range of motion. And then the last one is thawing stage. This one range from 5 months and can go up to 2 years. So this one is progressively return of the range of motion of the shoulder, but usually it will be difficult to go back to the normal range of motion. It will still be a limitation. And then for history wise, usually patient complain of diffuse severe pain, usually at night, and then reduce in range of motion. And then in history, actually we can take more history to rule out other differential diagnoses for frozen shoulder. So for example, history of trauma, history of post-surgical or post-stroke, or any history of chronic subluxation of the shoulder. And then also get the history of any repetitive motion, for example in athlete or worker that have repetitive overhead movement. Need to rule out other like subacromial issues. Okay, and then for physical examination, look for any surgical scar, look for any wasting of the muscles, and then usually difficult to get a full range of motion due to the pain, but the most distinct feature is a difficulty in abduction and external rotation. And then patient will not able to improve the range of motion despite helping patient passively. For imaging, for X-ray is not much of a help, but if for frozen shoulder patient, at most you can see osteopenia on X-ray, and to rule out other pathology as well lah, like fracture, subluxation of the shoulder. For ultrasound, we are able to visualize possibly thickening of the ligament, and then increase vascularization, and then in some patients they might have some increase in fluid over the joint space lah, that indicate inflammation. For dynamic ultrasound, possibly can see a reduce in movement of the muscles. And then for treatment wise, it will be divided into operative and non-operative. So non-operative, we can give patient gentle ROM of the shoulder lah, like a pendulum swing, and then if there is a severe pain, can offer intra-articular steroid injection. But if let's say very back pain, can offer a suprascapular nerve block as well. Okay, and then the hydrodilatation will depends on differ each patient lah, depends, can with or without hydrodilatation. And then offer patient analgesic. Usually we give N6, and then progressively review patient more frequent, like 4 to 6 weeks, and then can increase the physiotherapy to increase the load lah, like doing exercises, external rotation and internal rotation abduction with resistant band. And then if it doesn't improve, we allow up to 2 years lah, but if it doesn't improve or condition worsen, we can refer for surgical management, where orthopedic can do a manipulation under anesthesia, or they can do a capsular release for the patient. That's all. Thank you.